Good afternoon, ladies and gentlemen, and welcome to today's webinar presentation on bone health in anorexia nervosa. And this is a special presentation brought to you by Eating Disorder Hope in collaboration with Massachusetts General Hospital at Harvard Medical School. We're delighted to bring you today our presenter, Dr. Melanie Shore, who will be offering this discussion on bone health and anorexia nervosa. Before we get started, we would like to let you know that you will have the opportunity to submit text questions to our presenter today by typing your questions into the questions pane of your control panel. You may send in your questions at any time during the presentation, and we will be collecting these and addressing them during the Q&A session. And now I would like to introduce our presenter, Dr. Melanie Shore.
Hi, thanks so much for having me on the ED Hope webinar today. I'm delighted to be here and speak to you about bone health in anorexia nervosa. I am an endocrinologist at Massachusetts General Hospital and Harvard Medical School, and my clinical and research interests are in bone health as it relates to women and men with eating disorders. So the key points of the talk today is that bone health is a common and potentially severe complication in anorexia nervosa for both adolescents, women, and men, and that bone loss increases the risk of fracture now and in the future. We can assess the degree of bone loss by measuring bone density using a special scan called a DEXA scan, and that weight recovery and resumption of menstrual periods for women is key in regaining bone density. And I'd like to end by discussing the studies that are underway to investigate further therapies for bone loss. I'd like to start with an illustrative case to help frame our discussion. I saw a 20-year-old woman who had presented to her primary care physician for her first appointment, and she had been diagnosed with anorexia nervosa 3 years ago. She was concerned because she had not had a menstrual period in 4 years, and she was running about 5 miles daily, 6 days a week, and was taking an over-the-counter calcium and vitamin D supplement. The primary care physician ordered a DEXA scan to assess her bone mineral density, and these are the reports. So this is a very typical bone density scan. In the upper left-hand corner, although the image didn't copy very well, is actually the image of her spine, looking at it from the front. And then on the right-hand side of the page, you can see the readout that we get that includes information about the absolute bone mineral density, which is the BMD, as well as these scores that we use clinically called the T-score and Z-score. The T-score compares your bone density to someone of your age, gender, and ethnicity. The T-score compares your bone density to a young person of your gender and ethnicity, and then the Z-score compares your bone density to someone of your age, gender, and ethnicity. So her Z-score at her total spine was negative 2.8, and the Z-score and T-score are reported in standard deviations, meaning that her bone density at her spine was 2.8 standard deviations below the average for someone of her age, gender, and ethnicity. And then if you look at her absolute bone mineral density of 0.714, and you can plot it on the axis here, you can see that it actually corresponds to the average bone density of an 85-year-old woman. So she had severe bone loss or osteoporosis as a result of her eating disorder. This is a picture of a scanning electron micrograph that looks at the comparison between healthy bone and osteoporotic or porous bone. Bone is actually not a completely solid organ. It has this trabecular sponge-like network that actually lends it increased strength to prevent from fracturing. But in people who have osteopenia, which is mild to moderate bone loss, or osteoporosis, which is severe bone loss, there's much more holes than there are trabecular network, and you can perhaps understand why the bone on the right would break or fracture more easily than the bone on the left. This is another image, again looking at it on a microscopic level using a 3D reconstruction of the wrist, that again shows that the bone on the right, which is corresponds to the image of a patient with anorexia nervosa, is less dense than the bone of the healthy subject on the left, and how that could be associated with an increased risk for fracture. Our bones are actually a living, breathing organ, just like any other organ in our body, and they change over the course of our lifespan. And this is a diagram or figure to show those changes in bone density across the lifetime. So during the teenage years and as well as through the 20s, there is a significant increase in bone mass or bone density until men and women reach their peak bone mass around the age of 30. And things that might happen during puberty or early adolescence that can affect peak bone mass can be detrimental later on in life, because we don't know of a way to go back and gain the bone density that wasn't gained during adolescence and young adulthood. Then into the 30s and 40s, we can do our best to maintain bone density, but there is a slow decline that's normal over time in bone density with aging, and that bone loss is accelerated in women during the menopausal transition during the 50s. So that's why you see that there's a steeper decline in bone density for women in their 50s than for men. In women with anorexia nervosa, we know that bone loss is both common and severe. This is a study that we did back in 2005 that showed that the majority of women with anorexia nervosa had some degree of bone loss. The red bars on the left are those women with osteopenia, and then the orange bars in the middle are women with osteoporosis, so the severe bone loss. And you can see, if you look at this very last bar on the far right-hand side, that less than 15% of women had normal bone density at all sites. And the sites that we particularly are concerned about when we measure bone density are the spine and the hip, as well as the total body. And we may also measure the wrist, which is called the radius, as well. And we care about low bone density in anorexia nervosa because of the risk of fracture. We know that the risk of the fracture rate is about 7 times higher than expected for age and gender in women with anorexia nervosa, and that 30% of women with anorexia nervosa report a history of fracture. And we care about fractures because they can result in pain, loss of mobility, and also loss of height if the fracture occurs in the spine. And we think being able to prevent fractures is important, and being able to diagnose osteopenia and osteoporosis early is important. And it's important to think about it because many people with osteopenia and osteoporosis don't know they have it because it's not painful until a fracture has already occurred. So what are the causes of bone loss or low bone density in anorexia nervosa? One of them is the direct effects of low weight and undernutrition from the disease, but there's also a number of hormonal changes that affect bone density and bone loss that are associated with hypothalamic pituitary axis dysregulation, which is a very long combination of words, and we'll talk about exactly what that is in the coming slides. But they include estrogen deficiency, which is the lack of menstrual periods in women, androgen deficiency, or low testosterone in men, high cortisol levels, known as the stress hormone, and low IGF-1 levels, which is a hormone related to growth hormone. The effects of these hormones on bone loss and bone density may be worsened in the setting of calcium or vitamin D deficiency. Vitamin D is important in order to be able to absorb calcium from our gut, and calcium is actually what mineralizes the bone. And also concurrent alcohol and tobacco use. I just like to think that anything that's toxic to any part of the body is also toxic to the bones, because the bones are a living, breathing organ, as well as excessive exercise that results in further energy deficiency is also detrimental to bone health and bone density and strength. So talking about weight and undernutrition in anorexia nervosa and how it relates to bone density, we know that both body mass index and lean body mass are important for bone density. Body mass index is the weight in kilograms divided by the height in meters square. And you can see that in this population of people across the weight spectrum, the higher the BMI, the higher the spine bone mineral density Z-score here. And similarly, perhaps even more important than body mass index, we know that lean body mass is important for bone density and strength because of this muscle-bone interaction, where higher lean body mass, seen here on the x-axis of this figure on the right, is associated with higher spine bone mineral density Z-scores. I've touched on this a couple times already, but just to emphasize that bone is a living tissue and that it's constantly being renewed. So healthy bone is constantly being renewed in that old bone that might have like micro stress fractures or micro damage in it, is being removed by these cells called osteoclasts. And then osteoblasts are the cells that come in after that and put down new healthy bone. So the osteoclasts and the osteoblasts work in conjunction with each other to constantly renew and repair bone. However, in anorexia nervosa, bone resorption, so the osteoclasts, exceed bone formation from the osteoblasts, and net bone loss occurs. To speak about some of the hormonal changes that are associated with bone loss in anorexia nervosa, there are a number of hormones made by the hypothalamus and pituitary that are dysregulated. The hypothalamus and pituitary, as you can see in this figure on the left, are two small glands that are next to the brain, and they secrete a number of important hormones that are listed here on the right. One is ACTH, which signals to the adrenal glands to make the hormone cortisol, which is known as the stress hormone. The pituitary also makes TSH, that signals to the thyroid to make thyroid hormone. The pituitary, in addition, secretes FSH and LH that signal to make testosterone in men and estrogen in women. And the pituitary also makes growth hormone that sends signals to both bone and muscle and are important for both bone and muscle maintenance. To speak about each of these different pituitary hormones separately, I first wanted to touch on reproductive axis abnormalities in anorexia nervosa. So in anorexia nervosa, there's decreased signaling from the hypothalamus to the pituitary to the ovaries in women or the testes in men. And the result of this is low estrogen levels in women with potentially absent menstrual periods, and men, low testosterone levels. And this, we know, the low estrogen and low testosterone levels contribute to bone loss. And the cause for this decreased signaling from the hypothalamus and pituitary is thought to be complex, and that both low weight, low fat mass, and other hormones that signal low energy availability essentially suppress the hypothalamic pituitary gonadal axis and cause the low estrogen and testosterone levels. There are also cortisol axis abnormalities in anorexia nervosa, but they're slightly reversed in that rather than having suppression of the axis, there's activation of the cortisol axis, and that signaling from the hypothalamus to the pituitary to the adrenal glands is increased. And this results in increased cortisol levels in anorexia nervosa, and this is a normal response to both the psychological and physical stress of the disease. We do know that these elevated cortisol levels are associated with more bone loss, and we've also done other research, as an aside, that shows that the high cortisol levels are also associated with other symptoms of the disease and comorbidities such as anxiety and depression. The growth hormone axis abnormalities in anorexia nervosa are also important in terms of bone health. Growth hormone made by the pituitary stimulates insulin-like growth factor 1, or IGF-1, production from the liver. And IGF-1, as I mentioned earlier, is important for both bone and muscle mass maintenance. However, in anorexia nervosa, the liver is resistant to growth hormone, meaning that it can't make enough IGF-1 in response to the levels of growth hormone that are present in the blood. And therefore, IGF-1 levels are lower in patients with anorexia nervosa. These low IGF-1 levels also contribute to the bone loss. As I mentioned in the illustrative case at the beginning of this discussion, bone density is assessed using a machine called a DEXA scan, which stands for Dual Energy X-ray Absorptiometry. It is like a mini X-ray machine where the patient sits on the scanner, and then an arm comes over and takes mini X-rays of the spine, the hip, and the wrist, and then you get the readout on the right that may look familiar to the case that we presented at the beginning of the webinar. And again, you get the information in the chart on the right-hand side, the most relevant information being the T-score and the Z-score, the difference between the two being that the T-score is comparing your bone density to a young adult, and the Z-score compares it to someone of your same age. And we typically define osteopenia as a T or Z score between -1 and -2.5 standard deviations below normal. And osteoporosis is when the score is greater than 2.5 standard deviations below normal. So now that we understand both the prevalence and the causes and how to diagnose osteopenia and osteoporosis in anorexia nervosa, I'd now like to talk about how we treat it. We know that weight recovery is very important for bone health because of that positive association between body mass index, lean mass, and bone density. Weight recovery that results in restoration of menstrual periods in women is key, as weight recovery without restoration of menstrual periods does not result in as much bone regaining as in a woman who has weight recovery as well as restoration of her menstrual periods. We also know that adequate calcium and vitamin D intake is important, as calcium or vitamin D deficiency worsens bone loss, but most women with eating disorders do receive enough calcium and vitamin D in supplements. We know that the recommended daily intake of calcium is probably somewhere around 1,000 to 1,200 milligrams, which ends up being about 3 to 4 servings of dairy products a day. And you can easily Google and find different charts and websites that show the that show the amount of calcium in different types of food. Vitamin D intake, the recommended intake varies based on what your baseline vitamin D levels are. Someone living in the cold Northeast during the winter who doesn't go outside much, such as myself, may actually have low vitamin D levels because the sun actually converts inactive to active vitamin D on our skin. So sunlight is important to have adequate vitamin D levels. So really knowing what your baseline vitamin D levels are most informative in terms of what your daily intake of vitamin D should be. Although the recommended amount is probably somewhere around at least 400 to 800 units. It's also important to pay attention to lifestyle factors, again, abstaining from smoking and alcohol, which are bad for your bones and also the rest of your health. And exercise programs must be individualized because overexercise that results in a further energy deficiency results in weight loss and amenorrhea, and we know that both of those are not good for bone health and actually counteract any potential positive benefit of weight-bearing activity on bones. Having a single bone density that shows evidence of bone loss is not as informative as having repeat bone densities over the course of a year or 2 or 3 in order to assess response to treatment and get an idea about if your bone density is remaining stable, increasing, or decreasing with your treatment program. There are also other treatments under study at Mass General involving different hormonal options for trying to improve bone density and reduce bone loss associated with eating disorders. So as I mentioned in that previous slide, we know that regaining menstrual periods is very critical to skeletal recovery. In this study that we did, that was published in 2006, we showed that women who were able to resume their menstrual periods had a 2.7% increase in bone mineral density over 1 year, versus those who did not have resumption of their menstrual periods had a 2.2% decrease in bone mineral density over 1 year. And this is despite a similar increase in weight between the two groups. I'd like to spend a minute talking about the role of oral contraceptives in women with anorexia nervosa, as the decision on oral contraceptives should be individualized. Although oral contraceptives do provide an exogenous source of estrogen in the pill for women with anorexia nervosa who may have low endogenous estrogen levels, there is no convincing data that oral contraceptive pills alone increase bone density in women with anorexia nervosa, and may actually be falsely reassuring by causing a period that's not actually a true menstrual period. However, oral contraceptive pills may help in preventing bone loss, but the data is not entirely clear, and this is one of our active areas of investigation. Of course, use of oral contraceptives or other contraceptive method is important for sexually active women, as even though you may not be getting your period, it's still possible to get pregnant. The role of estrogen-progesterone therapy in adolescents with anorexia nervosa is slightly different. We know that low estrogen during adolescence is especially problematic for bones because adolescence is a period of a great increase in bone density and bone mass. We do know that oral contraceptives do not increase bone density in adolescent girls with anorexia nervosa, but lower replacement doses of transdermal estrogen, so estrogen patches, that may more closely mimic puberty, may be more effective than oral contraceptive pills, but again, alone cannot normalize bone density. This study that we did that was published in 2011 shows the change in spine bone mineral density in women who with anorexia nervosa who weren't having menstrual periods and who did not receive estrogen, which is the red bar, who received estrogen patches, which is the green bar, compared to healthy controls. And you can see the women with anorexia nervosa who did not have periods but received estrogen patches during adolescence did have an increase in their spine bone mineral density compared to the women who did not receive estrogen patches, but that the increase was still not as great as it was for women of their age who are otherwise healthy. So I'd like to go back to our patient for a minute. When she learned that she had a bone mineral density that was that of an average 85-year-old woman, she was motivated to seek further treatment for her anorexia nervosa, and she was successful in having weight recovery and restoring her menstrual periods within the year. And when her bone density was repeated 1 year later, her spine bone density increased 6.7%, which is actually a very significant increase, but still did not normalize. So the key points of the talk is that bone loss is a common and potentially severe complication of anorexia nervosa in adolescents, women, and men. I didn't touch on men as much, mostly because we do lack a lot of information on bone health in men with eating disorders, but we do know that low testosterone is common in men with eating disorders, and that that's associated with bone loss, just as low estrogen levels are associated with bone loss in women. We care about bone loss because it increases the risk of fracture both now and in the future. And we can diagnose and assess bone loss by measuring bone density on a DEXA scan. In terms of treatment, weight recovery and resumption of menstrual periods are key to regaining bone density, and studies are currently underway at Mass General to investigate therapeutic medications to treat bone loss. Our goal at the Neuroendocrine Unit Bone Research Center is to advance bone health in adolescents and adults through research. And again, studies are underway to develop effective therapies for bone loss associated with anorexia nervosa, especially because bone loss may remain a long-term complication of the disease, even with weight recovery and restoration of menstrual periods. And so we're especially interested in providing therapeutic strategies and therapeutic potential for women so that to help with the potential long-term complication of bone loss.